So, hello everyone. Welcome to this discussion session of 𝗗cie𝗰𝗧𝘂 RDX series. So, I'm just about to start the session. Meanwhile, please let me know if my audio and video is good. I'll just wait for your comments so that I can start the session. So, please let me know if my audio and video is good. Right. So I think we are good to start. Yes, I think we are good to start. Okay. Right. So let me start the session. Hello and good evening to all of you. So as I told you, this is just going to be a short discussion of the 20 MCQs asked for 𝗗cie𝗰𝗧𝘂 RDX exam. So I've selected these 20 questions mostly based on the 𝗗cie𝗰𝗧𝘂 previous year topics. So what I want to tell all the 𝗗cie𝗰𝗧𝘂 aspirants is that focus on these topics, because sometimes, and we have seen often in 𝗗cie𝗰𝗧𝘂 that questions get repeated from the same topic, if not the exact question. So you will have to pay attention to this session. Right, let's start. As I said, no detailed discussion, concise, to the point discussion only, right? Coming to the first question. A 25-year-old patient with dental caries is scheduled for a tooth extraction. Which of the following conditions does not require antibiotic prophylaxis to prevent infective endocarditis? Option A, previous history of endocarditis. Option B, prosthetic heart valve. Option C, untreated cyanotic congenital heart disease. And option D, mitral valve prolapse. First of all, at the outset, let me tell you that for 𝗗cie𝗰𝗧𝘂, the topic of infective endocarditis is very important. So this question, almost a similar one, was asked in 𝗗cie𝗰𝗧𝘂. In another session, they asked about blood sampling in case of infective endocarditis in the context of blood cultures. And sometimes they have asked questions based on the management. I think in one of the sessions they have asked about the management of enterococcal endocarditis as well. So overall, this topic is very important. Coming to this specific question, well, I have taught you in my lectures this very important table on the high-risk cardiac lesions for which endocarditis prophylaxis is advised. And this table, I told you in my lectures also, is very, very important. So out of these high-risk cardiac lesions, you can see that 3 of them. Number 1, prosthetic heart valves. Number 2, prior endocarditis. And number 3, unrepaired cyanotic congenital heart disease. They are there in the options. I would strongly urge you to go through the remaining, which I have stressed in my lectures as well. So if you come back to this question, you can already eliminate option A, option B, and option D. So what is the automatic choice? It is going to be mitral valve prolapse. So mitral valve prolapse is not an indication for antibiotic prophylaxis to prevent infective endocarditis. So clear answer is option D. At the same time, I want my students to also focus on what are the antibiotic regimens to be used in such cases, which may be a potential question for 𝗗cie𝗰𝗧𝘂. You have to know the standard oral regimen consisting of amoxicillin, and in patients who are not able to take the oral medications, you can go for parenteral ampicillin. And another potential question they may ask, they may give a clinical scenario of a patient who is requiring infective endocarditis prophylaxis, and there might be a mention of penicillin allergy in that patient. So what are the drugs that you should use or consider in such a case? Cephalexin, clarithromycin or azithromycin, and doxycycline. Okay, and again parenteral, you can go for cefazolin or ceftriaxone. So this is again very important. I just wanted to highlight what other questions can be asked from the same topic. I hope all my children are comfortable. Yes, can you give me a thumbs up in the chat box? Okay, right. Shall I go to the next question? Right. Okay. Next question. Which of the following is specifically recommended for the prevention of chronic migraine but not episodic migraine? Now the options are propranolol, divalproate sodium, flunarizine, and onabotulinum toxin A. So all the four options are drugs which are used for prophylaxis of migraine. But the question specifically is on chronic migraine. So when do you call it chronic migraine? Do you call it chronic when it has been there for last many years? Is it like that? No. Chronic migraine has a definition. So chronic migraine means the patient is having headache at a frequency of more than 15 days in a month. That is when you call it chronic migraine. Okay, and all other types of migraine, you call it episodic migraine. Now we know that the list of prophylactic medications that I have taught you, a list of drugs that is mainly in the context of episodic migraine. So propranolol is useful for episodic migraine but not for chronic migraine. Again, divalproate sodium, again only for episodic migraine. Flunarizine, again episodic migraine. But this drug, onabotulinum toxin A, this has been FDA approved for the use in chronic migraine but not episodic migraine. This is one point all my children should know. And I also want you to let you know that the topic of migraine, especially management of migraine, both acute treatment and prophylaxis, you've got to learn thoroughly. You can get scenario-based questions. You can get questions linking medicine and pharma. And recently also we had exams wherein, this knowledge is often tested. Even for NEET PG as well, the topic of migraine management is very, very important. Please also revise the monoclonal antibodies which are having utility in migraine, and also just have a look at the CGRP antagonist that are the GPANs which can be used for migraine. Clear? Okay. Let's go to the next question. Okay. Now I want all my children to first comment. Everyone should comment in the chat box what is the diagnosis. A 60-year-old male with a history of chronic alcohol use presents with 2-week history of productive cough, fever and progressive shortness of breath. Chest radiograph is shown below. Which of the following antibiotic regimens is most appropriate for this patient? Please have a look at the chest radiograph. You can see a thick-walled cavity with an air fluid level, and in the context of the short duration illness with fever, cough and breathlessness, you can think of a possibility of lung abscess. You can think of a possibility of lung abscess. And in the context of alcoholism, maybe the patient has developed this as a sequelae of aspiration. So what do you think? What antibiotic should definitely be there in the regimen? Anaerobes. Anaerobes are commonly implicated in the causation of lung abscess in such patients. So definitely I need an antibiotic that is having good anaerobic coverage, which means I can eliminate the options of ciprofloxacin, cephalexin and vancomycin, and my automatic choice will be clindamycin, which has got good anaerobic coverage. Okay, so the answer is option B. And I always tell my students in the X-ray, okay, when you interpret, please also look at the history as well, which will help you come to the actual diagnosis. And for students who are preparing for 𝗗𝗗CT, I've got a dedicated group for discussion of the 𝗗𝗗CT previous year topics. So we'll be discussing more and more topics in the coming few days leading to 𝗗𝗗CT, less than a month left. So this is not an open group, it's a closed group only for seriously preparing candidates. And if you are preparing for 𝗗𝗗CT, you can just send me a message in my Instagram, okay, because WhatsApp message I may miss. So please send me a message in Instagram This is the QR code of my Instagram page. You can send me a message. I'll be adding you to this group of previous year topic discussion of medicine, right? Okay, let's go to the next question. So 64-year-old woman is admitted with sudden onset headache and diffuse subarachnoid hemorrhage in her basal cisterns. Angiography shows a posterior communicating artery aneurysm which is treated with endovascular coiling. So the clinical scenario is that of a patient who is suffering from subarachnoid hemorrhage without any doubt, and you've got an aneurysm that has ruptured. So this has been addressed with endovascular coiling, right? Now the patient has developed a late complication, and what is that? 6 days later, the patient has developed a left-sided weakness. So there is a new motor deficit that has developed not immediately but 6 days after the subarachnoid hemorrhage, following which the patient has become drowsy. And obviously, when such a scenario occurs, the clinician will definitely go for a repeat imaging. So what is there in the repeat imaging? There is an infarct in the right cerebral hemisphere which has contributed to the development of left-sided weakness. And her laboratory studies do not suggest infection or metabolic dysfunction. And what is the most likely cause? So what do you think? In this patient with SAH developing a delayed neurological deficit, what could be the possibility? Look at option A, delayed cerebral ischemia. We know that it is a well-recognized complication of subarachnoid hemorrhage, which usually occurs 4 to 14 days after the subarachnoid hemorrhage. Okay, 4 to 14 days. So here the patient has developed symptoms at 6 days. Okay, so what is the reason for the delayed cerebral ischemia? It is usually due to the vasospasm. Vasospasm following a rupture of blood vessel, there is reflex vasospasm as a protective mechanism, but again that can lead on to problems, and that is the reason for delayed cerebral ischemia, and that can lead on to infarct as well. So I think there is a good chance that option A is the answer. Let us look at the remaining options. Next option is hydrocephalus. Hydrocephalus can also occur as a complication of subarachnoid hemorrhage because of the blood obstructing the CSF flow, and that can also cause neurological deterioration, mostly in the form of headache and decrease in sensorium, usually not as a left-sided focal weakness. But again, one important point you have to note is CT has been taken and CT is showing an infarct. So there is no evidence of hydrocephalus. So if at all there was hydrocephalus, the CT should have shown that. So CT is not showing any evidence of hydrocephalus, and hence I am not considering it. What about rebleeding? Rebleeding is another complication of subarachnoid hemorrhage which occurs due to rupture of the aneurysm, or you can say re-rupture of aneurysm. But again, if this was a rebleeding, definitely the repeat CT should have shown bleed instead of infarct. So hence I am eliminating that option as well. Coming to the next one, SIADH, which is syndrome of inappropriate ADH secretion. Is it a recognized complication of subarachnoid hemorrhage? Yes, SIADH can occur following subarachnoid hemorrhage. SIADH can result in decreased sensorium. It can result in seizures, maybe not weakness. One side weakness is unusual due to an SIADH leading to hyponatremia. But over and above that, you can also see that in the laboratory studies, there is no evidence of any metabolic dysfunction. So if at all there was SIADH, there would have been evidence of hyponatremia, and that is also not mentioned. So there is no doubt about this. The answer is going to be option A. So if all my children are convinced that option A is the answer, please give me a thumbs up in the comment section. All my children, if you're convinced, please give me a thumbs up, right? Okay, let's go to the next question. A 35-year-old female is being evaluated for dry eyes and dry mouth. Now, my dear children, whenever you hear these two terms, dry eyes and dry mouth, in a female, just let me know in the comment section what disease are you thinking about. Forget about all the other stuff that has been mentioned, what disease are you thinking about? Many of you are already thinking about this disorder, which is Sjogren's syndrome, correct or not? Many of you are already thinking about Sjogren's syndrome. And let us see what are the laboratory findings. A sodium level of 139, chloride 112, bicarbonate 15, potassium 3, and the urine studies are also given. So when you get a patient with Sjogren's syndrome, okay, and with a bicarbonate of 15, which means there is a definite evidence of acidosis. So there is definite evidence of acidosis, and in the context of a metabolic acidosis, you can have a high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. So you know that the normal anion gap, the value comes to around 8 to 12 milliequivalents per liter. That is the normal value of anion gap. Okay, 8 to 12 milliequivalents per liter. So in this patient, what is the value of anion gap? We know that anion gap is the serum anion gap is sodium minus chloride plus bicarbonate. This will be anion gap, which means 139 minus a chloride value of 112 plus a bicarbonate of 15, so which makes it 127, and the value is 12. So we can almost say that this patient is having a normal anion gap metabolic acidosis, or can I call it NAGMA, normal anion gap metabolic acidosis, right? Okay, so Sjogren's syndrome with a normal anion gap metabolic acidosis. So we know that Sjogren's syndrome is very well known to cause renal tubular acidosis. And what type of renal tubular acidosis is well described in case of Sjogren's syndrome? It is usually the distal RTA, which is also known as type 1 renal tubular acidosis. Now, to further substantiate that the diagnosis is type 1 RTA, you can also look at the urine pH. So you can see that despite the acidosis, the urine pH is on the higher side. So that means there is some problem with the distal acidification of urine, because of which the pH of urine is on the higher side. So it is quite evident in the context of all this, along with hypokalemia, we know that there is significant hypokalemia due to a distal RTA in patients with Sjogren's syndrome. And it is very well documented. Severe hypokalemia can result as a manifestation of renal tubular acidosis type 1 in Sjogren's syndrome. The answer for this question is going to be option A, type 1 renal tubular acidosis. So if all of you are convinced on this, please give me a thumbs up so that I can move to the next question. Coming to the next question, a simple one. We'll finish this question quickly. 38-year-old man with HIV infection is presenting with 4 weeks of diarrhea, fever and weight loss. Which of the following test makes the diagnosis of CMV colitis likely? Okay. Now, if you look at the clinical scenario, we very well know that CMV colitis is one of the GI manifestations of HIV infection, especially in patients whose CD4 count is less than 50. So in this particular patient, if you want to make a diagnosis of specifically the CMV colitis, what test are you going to go for? The first option says serum CMV PCR. Well, the serum value of serum CMV PCR can be used to detect viremia, but it is not having a direct correlation with colitis. Okay, so just because there is a positivity in the result, you cannot be sure that the patient is having colitis. So hence, I am not considering this as the first possibility. Colonoscopy with biopsy, well, definitely it should be considered, and you can see the inclusions as well, which will further substantiate the diagnosis of CMV colitis. So that definitely is the diagnosis that I am looking at, or the answer that I am looking at. Stool CMV antigen, again not relied upon, so is stool CMV culture. The best answer for this question will be option B, colonoscopy with biopsy. Coming to the next question, which of the following drugs has best shown to reduce cardiovascular death in patients with heart failure with preserved ejection fraction? Now let me tell you, all my dear children preparing for 𝗗𝗗CT, please note that topic of heart failure is ultra high important for your exams. You please screen through the last few 𝗗𝗗 papers. Almost every paper is having question on heart failure. And in one of the exams last year, in a single paper, there were 2 questions based on heart failure. And you know that heart failure can be with a reduced ejection fraction and with preserved ejection fraction. Most of the times the question has revolved around heart failure with reduced ejection fraction. And I have always told you in my lectures that in such patients with heart failure and having reduced ejection fraction, there are 4 pillars of treatment. What are the 4 pillars? Number 1, you have got 𝗟𝗏, that is the angiotensin receptor blocker neprilysin inhibitor. Then you have got the beta blockers. Then you have got mineralocorticoid receptor antagonist, and also you have got the SGLT2 inhibitors. These are the 4 pillars of management in patients with heart failure with reduced ejection fraction. If 𝗟𝗏 is not available, you can go for other alternatives like AC inhibitors as well as angiotensin receptor blockers. And with regards to the beta blockers, what are the preferred beta blockers? The MBC beta blockers, metoprolol, bisoprolol and carvedilol. So these are the important drugs that you have to consider. But the question specifically is on heart failure with preserved ejection fraction. Remember, in the heart failure with preserved ejection fraction, the data is not that conclusive as in heart failure with reduced ejection fraction. If you look at the drug with proven benefit in reducing mortality in patients with heart failure and preserved ejection fraction, it is mainly the SGLT2 inhibitors. The other drugs do not have proven mortality benefit in such patients. So in patients with preserved ejection fraction being mentioned, you have to look out for the option of SGLT2 inhibitors, and among the options, dapagliflozin is going to be the answer. It is an SGLT2 inhibitor. I hope in the revision videos, in the QRP videos in the DocTutorials app, there is a very concise video about heart failure. Please go through that video. I have explained this particular slide on the pharmacological therapy of both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So for this question, the answer is going to be option D. If all my students are convinced about this question, please give me a thumbs up. All those who are seriously preparing for the November 𝗗𝗗CT, please do join me in my 𝗗𝗗CT PYT discussion group, where I'll be discussing the last 5-year papers, important questions from medicine and the integrated ones including I'll be discussing. Coming to the next question. This is actually a ditto repeat from one of the previous 𝗗𝗗CT questions, but I just wanted to see how many of you have gone through the repeat questions. So if you have not seen this question, it means that you have not gone through the 𝗗𝗗 previous year questions. So 40-year-old woman presents with symmetric joint pain involving multiple joints with morning stiffness that gradually improves over an hour. So immediately takes a clinician to suspect what disease? Rheumatoid arthritis, right? Okay. Which of the following statements regarding the underlying condition is correct? And these sort of questions wherein multiple options are correct, this is often asked in 𝗗𝗗CT. So please expect such questions. So first is NSAIDs improve the symptoms and have got disease modifying activity. Now for rheumatoid arthritis pain, yes, you can give NSAIDs and definitely it will help in the relief of pain. But NSAIDs are not categorized as disease modifying anti-rheumatoid drugs. It does not have disease modifying activity. But remember, in a condition like ankylosing spondylitis, NSAIDs have some disease modifying activity. So rather than just a pain relief, there is some sort of a disease modifying activity in the context of ankylosing spondylitis. Next question. Next option, absence of erosion on X-ray rules out the diagnosis. So we know that in case of rheumatoid arthritis, one of the earliest X-ray change is the presence of erosions. But please understand, even before erosions come, sometimes you may have the finding of periarticular or juxta-articular osteopenia. So at that particular stage, which is a very early stage, you may not have obvious erosions. So just because you do not have erosions in the X-ray does not completely rule out rheumatoid arthritis, because it still can be an early stage where you can only appreciate periarticular osteopenia. And being an inflammatory disease, patients with rheumatoid arthritis will definitely have a raised ESR as well as CRP, as both are inflammatory markers. And coming to the next point, HLA-DR4 is related to the prognosis. This again is a correct statement. Patients with HLA-DR4, they are having more severe rheumatoid arthritis compared to others. That is also correct. So what is the answer here? Answer is option C. 3 and 4 are correct. That will be the answer here. I hope all of you are convinced, and please give me a thumbs up if you have got this right for the 𝗗cie𝗃𝗃 RDX exam. Coming to the next question, 22-year-old male with sickle cell anemia presents with frequent episodes of painful vaso-occlusive crisis. He has no history of stroke or organ damage. Which among the following medications is most effective in reducing the frequency of his pain episodes? So the question is very straightforward, and remember, a similar question has been asked before in 𝗗nic𝗃. So sickle cell anemia management is very important. You have to be familiar with the drugs as well as their mechanism of action as well. This question was relatively straightforward, and among the options, the only drug, we know that methotrexate is an antimetabolite not used in sickle cell anemia. Azathioprine again not used. L-Trombopac in ITP, this also not used. So this answer will be hydroxyurea, and we know that hydroxyurea will increase the HbF levels, and this will inhibit sickling and reducing the chance of developing vaso-occlusive crisis. So hydroxyurea acts by increasing the fetal hemoglobin that inhibits sickling. Clear? So remember the basic plan of management of sickle cell anemia. You will start with hydroxyurea and add voxelotor if anemia persists despite giving hydroxyurea. And if still the vaso-occlusive crisis continue, you can consider adding crizanlizumab. And in selected patients, you can also use transfusions. If it was a severe case, you can see in this particular patient, there is no history of any stroke or organ damage. But in severe cases, you can consider stem cell transplantation. Anyway, for this particular question, there is no option of stem cell transplantation in the question. Okay, right. If it was there also, my answer would have been hydroxyurea, because there is a specific mention that there is no history of stroke or organ damage. Coming to the next question. Now it's a big question and they have given so much of information, right? 7-year-old boy, progressive gait imbalance, difficulty in speech, on examination, conjunctival vascular lesions, nystagmus, truncal ataxia, distal sensory loss. His past history reveals recurrent lower respiratory tract infection. Laboratory evaluation shows decreased IgA, IgG2. What is most consistent? Now, if this question gives you some vertigo, don't worry. Please remember, when you have a long question in hand, don't panic. Just look at the key points and the buzz points. Now look at this. What is the age? 7-year-old boy. 7-year-old boy. A 7-year-old boy with gait imbalance, which could very well be ataxia. So first decade of life, gait ataxia with conjunctival vascular lesions, which could be telangiectasia. So ataxia and telangiectasia in the first decade of life. What disease are you thinking about? Yes, 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 it is 𝗗𝗃cie𝗬𝗂𝘃, right? And all the other points that have been mentioned here are just other associated features of 𝗗𝗃cie𝗬𝗂𝘃. And what do you think is most consistent? Selective degeneration of the anterior horn cells resembling SMA? Absolutely wrong. It's not at all related to this condition. Increased risk of lymphoid and breast malignancies? Absolutely right. Patients with 𝗗𝗃cie𝗬𝗂𝘃 have got an increased risk of lymphoid and breast malignancies. Next option, vitamin E deficiency as the primary underlying defect. Well, vitamin E deficiency can produce ataxia. Correct. That point is correct. But vitamin E deficiency is not related to 𝗗𝗃cie𝗬𝗃𝘃. In isolation, vitamin E deficiency can produce ataxia. That's it. But it is not at all related to this particular disorder. Normal thymus with isolated cellular immune deficiency, that is also wrong. So the answer will be option B, increased risk of lymphoid and breast malignancies. Okay, so this is a message I want to tell all my children, not just about this question, in your actual exam as well. Suppose there is a tough question and you're finding it tough at first look. Still, please be on the active search for buzzwords. Please understand, a topper in an exam is usually not confident with all the questions. There are questions where the topper also takes guesses, but those guesses will be calculated, educated guesses. Means they'll be able to identify the buzzwords. It's not that they know everything about that particular disease. So you have to be a bit smart as well, my dear children. And if you feel, sir, I don't think I've got that ability, I will tell, dear children, please keep practicing questions again and again. With constant practice, you can improve. You may not be the best now, but please keep practicing again and again and again. Things will fall in place. Okay, so don't worry. Coming to the next question. A patient with lupus nephritis and biopsy showing wire loop lesions is started on induction therapy. Which of the following agents is or are recommended for induction treatment? Well, this again was asked for the recent 𝗗𝗗𝐼CT exam. I purposefully put the ditto question just to see again how many of my children have gone through the PYQs and PYTs for 𝗗𝗗𝐼CT. So with less than a month remaining, I expect all of my children to be thorough with it. Now, SLE has always been a hot favorite for 𝗗𝗗𝐼CT, but this time they have specifically asked a question on the management of lupus nephritis. So look at the options: high dose glucocorticoids, high dose glucocorticoids plus cyclophosphamide, rituximab, mycophenolate mofetil. In the next 3 minutes, let me quickly summarize the management of lupus nephritis, just the important points. Well, all of you must be already familiar with the 6 classes of lupus nephritis. Yes. Now coming to class 1 and class 2, where the disease is limited to the renal mesangium. Overall, it has good prognosis and hence no specific therapy is required for those 2 stages, except in the context of maybe adding an angiotensin receptor blocker or AC inhibitor to retard the proteinuria. Okay. Coming to class 3 lupus nephritis, which is focal proliferative. If it is mild class 3, you can treat it with steroids alone. There is no need of any combination therapy. But a severe form of class 3 has to be treated as class 4. And remember, class 4 is always combination therapy. So class 4 lupus nephritis, you have got induction phase and maintenance phase. Remember, you have got to be aggressive in the induction phase. You have to give the patient a combination of high dose steroids plus either cyclophosphamide or mycophenolate mofetil. And then when it comes to the maintenance phase, you give the patient either MMF or azathioprine. And what are the other approved add-ons that may be considered, not mandatory, may be considered? One is voclosporin and the other is belimumab. Belimumab is a B lymphocyte stimulator inhibitor, that is B-less inhibitor. And refractory cases of class 4 lupus nephritis, you can also consider rituximab. Coming to class 5 lupus nephritis, you can go for immunosuppression as well as anticoagulation. Why anticoagulation in class 5? Class 5 lupus nephritis, many patients have got anti-phospholipid antibody positivity and there is high chance of development of thrombosis. So anticoagulation may be considered in patients with class 5 with positive anti-phospholipid antibodies. Coming to class 6, you can go for dialysis or renal transplantation. Okay. So for this question, the answer is going to be option B, high dose glucocorticoids with cyclophosphamide. Coming to the next question, which of the following is not a core clinical characteristic of NMO spectrum disorder? Now, at least a few students would have found this question tough. But again, this is not a new question. This is also a repeat question from 𝗗𝗗𝐼CT. Exact question was asked 3 years back in the 𝗗𝗗𝐼CT exam. What is NMOSD? It is neuromyelitis optica spectrum disorder. So all of you have studied in detail about multiple sclerosis, which is a demyelinating disorder of the central nervous system. Similarly, neuromyelitis optica spectrum disorder is also a demyelinating disorder of the central nervous system. So what are the manifestations of NMOSD? So many manifestations. But the question is very specific. It is on the core clinical characteristics. So my children, since it has been asked once in 𝗗𝗗𝐼CT, and not once actually, because there was another question again based on the ocular manifestations in another session. So the topic of NMOSD for 𝗗𝗗𝐼CT especially is very important. For NEET, I have not seen questions being asked from NMOSD, but for 𝗗𝗗𝐼CT, it has been asked twice. So this screenshot is from Harrison on the core clinical characteristics of NMOSD, which I have already explained in my lectures in class as well. So one is optic neuritis is a core clinical characteristic. Next is acute myelitis. So optic neuritis can occur in MS as well. But in case of NMOSD, can you tell me how different is the optic neuritis of NMOSD in comparison to that of multiple sclerosis? This one will be a bilateral optic neuritis in comparison to multiple sclerosis, which is unilateral. And just like MS, here also you can have myelitis, which is an acute myelitis. Then you can have affection of certain specific areas, like you can have area postema syndrome, wherein patient present with unique manifestations like recurrent hiccups, which you cannot explain by any other cause. Then acute brainstem syndrome that can cause demyelination involving the brainstem. A symptomatic narcolepsy, which is also referred to as a diencephalic clinical syndrome, which occurs due to hypothalamic dysfunction. And then is the symptomatic cerebral syndrome with NMOSD typical brain lesions, which are relatively large lesions compared to the small ovoid lesions of MS. So if you come back to this, you can see symptomatic cerebral syndrome, yes, it is a core clinical characteristic. Area postema syndrome, yes. Optic neuritis, yes. Chronic myelitis, no. It is acute myelitis, and the answer is going to be option B, right? Let us go to the next question. Okay, so hope all good till now. Yes, give me a thumbs up if you are all with me. If you are all attentive and listening to me, give me a thumbs up. According to the Wells clinical prediction rule for pulmonary embolism, which of the following factors carries the highest likelihood of pulmonary embolism? So basically, Wells clinical prediction rule is actually predicting the risk of pulmonary embolism. Okay, so you can see this screenshot from the latest Harrison Wells clinical prediction rule for pulmonary embolism, which are listing a series of features, and you can see points have been assigned to it. So if you look at the points, the more weightage, 3 points have been assigned to clinical signs of DVT, an alternative diagnosis less likely than pulmonary embolism. Then for heart rate more than 100, so tachycardia, immobilization more than 3 days or surgery in the previous month, 1.5 points. History of DVT or pulmonary embolism, 1.5. Hemoptysis 1, malignancy 1. So according to the current literature, if the total score is above 6, it indicates high probability of pulmonary embolism. 2 to 6 intermediate probability, and score less than 2 is low probability, right? So if you look at this, hemoptysis, clinical signs and symptoms, yes. Clinical signs and symptoms, it is 3 points. You have to look at this as well. So hemoptysis you can see is only 1 point, whereas rest or immobilization it is 1.5 points. Whereas if the patient is having history of malignancy, that is also taken to be 1 point. Okay, so the answer is going to be option B. Okay, all comfortable? Give me a thumbs up if I can go to the next question. Yes, right. Now, next question, which of the following components of the jugular venous pulse corresponds with the isovolumetric contraction phase of the cardiac cycle? Now, if you have attended my cardiology lectures, I've always showed you this particular wagon wheel. I've always told you this is very important. You will have to stick it in front of your study table. Okay, if you remember this picture, I've told you this phase is corresponding to the A wave. This one, that is the isovolumetric to the C wave. This will be the V wave, sorry, A wave, C wave. This will be the X descent. This will be the X descent, X descent. This will be the V wave. And this will be the Y descent. The question specifically is on the which corresponds to the isovolumetric contraction phase. So this is the isovolumetric contraction phase, and that is corresponding to the C wave. Answer for this question will be option C. Remember, this question, a similar one, was asked for 𝗗𝗗CT November 2021. So this is again a repeat question. You cannot get these questions wrong. Okay, these are simple questions, but again, do not be careless. Please do revise these as well. Coming to the next question, given below are the contrast enhanced MRI brain sequence and the diffusion weighted MRI sequence of a patient with intracranial space occupying lesion. What is the likely diagnosis? Options: abscess, infarct, glioma and tuberculoma. This again is important for 𝗗𝗗CT, the topic of ring enhancing lesions. Very, very important. So you can see that the two images, image number 1 is a contrast enhanced MRI sequence. Image number 2 is a diffusion weighted MRI sequence. You can see a very well described ring enhancing lesion with a central core. You can see in image 1. Image 2, you can see that the area corresponding to the core is having diffusion restriction. Now I have told you that there are a list of differential diagnoses for ring enhancing lesion, and in most of the 𝗗𝗗CT exams you get a question from this area of ring enhancing lesion. So for this particular question, what is going to be the answer? The clinch is the diffusion restriction. So remember the golden point. You listen to me. You listen to me, all of you. Remember the golden point. If you get, remember, you say along with me, if you get a ring enhancing lesion with diffusion restriction, then you have to consider it is cerebral abscess. Okay, cerebral abscess. Option A is the answer. So always once again say along with me, a ring enhancing lesion with diffusion restriction, cerebral abscess. A similar question was also asked in the recent, 2024 NEET PG exam as well. Okay, right. Coming to the next one. Among the following infections, the least common cause of AV block. So usually in your exams, questions do come from the area of AV block. It has been repeatedly asked in the 𝗗𝗗CT, and most of the times it is ECG based question. But this time I have tested your theoretical knowledge on this particular topic. So AV block can have so many infectious causes. If you look at the options, Lyme's disease, Chagas disease, bacterial endocarditis, HIV. Well, what are the infections that can cause? Lyme carditis can produce AV block, and it is very well known to produce AV block as well. What about endocarditis? Endocarditis producing AV block is usually as an extension of infection. That is, when there is some sort of a perivalvular abscess, especially involving the aortic valve region, which can extend into the region of the AV node, and that can produce AV block. So it is usually a complicated bacterial endocarditis with a perivalvular abscess that results in AV block. Viral myocarditis, Chagas disease and toxoplasmosis can also result in AV block. If you look at the options, option A, eliminated. Chagas disease, eliminated. Bacterial endocarditis, eliminated. Now what about HIV infection? Let me ask you one question. You answer me in the comment section. Can HIV affect the cardiovascular system? Yes or no? Answer is yes, it can affect. But usually, when it comes to conduction abnormalities, AV block is less likely. HIV can produce myocarditis, and very rarely, when the inflammation also involves conducting system, very rarely it may produce AV block. But if you look at this question with the other options in hand, the best option here will be HIV. Okay, right. So let us go to the next question. Which of the following statements about Hammond's sign is false? So you might have heard about Hammond's mediastinal crunch, right? So this is a simple factual questions. Can I get factual questions for 𝗗cie𝗰𝗃? Possible. That is what I said. You should expect everything. You can even have factual questions like this as well. So seen in pneumomediastinum is true. So the question is false. So I'm eliminating this option. It is crunching or clicking noise is also true. It is synchronous with heart rate is also true. Coming to last, best heard in sitting and leaning forward position. That is not correct. That is not correct. That is a false statement. It is seen or it is heard best in the left lateral decubitus position. The answer is going to be option D. Coming to next question, which of the following agents is used in the treatment of refractory ITP? So what is ITP? Immune thrombocytopenia is the new term. The old term was idiopathic thrombocytopenic purpura. Now it is better coined as immune thrombocytopenia. So which is used? Idarucizumab, we know that it is reversal agent for dabigatran, not considered in ITP management. Romiflostim, definitely it is a thrombopoietin receptor agonist that can definitely be used in the management of ITP. So definitely possible. Anakinra, interleukin 1 antagonist. This is used in case of rheumatoid arthritis as well as adult onset Still's disease. Rheumatoid arthritis and adult onset Still's disease. Tofacitinib again is used in other conditions like rheumatoid arthritis. So that again is not going to be the answer. Here it is simple, straightforward, Romiflostim. So it is basically platelet stimulator. Okay, right. Coming to next question. Which of the following causes hypokalemia with metabolic alkalosis and hypertension? So what do you think is the answer for this? I need answers in the comment section. Now the moment I read hypokalemia with metabolic alkalosis. Okay. So remember, Lidl can produce hypokalemia. Gittelman can produce hypokalemia. Barter can produce hypokalemia. And in all of these, you can have metabolic alkalosis. But in Gordon syndrome, it is not hypokalemia, it is hyperkalemia. So remember, the 4 options that have been given, they are all disorders associated with the renal tubular electrolyte handling. So they are disorders wherein the renal tubular electrolyte handling is affected. So you have got Liddle syndrome, Gittelman, Gordon and Barter. So in case of Liddle syndrome, you can see the thick ascending limb of the loop of Henle is what is affected. In case of Glittman syndrome, it is DCT that is getting affected. Gordon also, that is DCT, that is, Liddle syndrome, instead of, it is Bartter here. So, Bartter syndrome, thick ascending limb of loop of Henle. In Liddle syndrome, it is the collecting duct that is getting affected, mainly the cortical collecting duct. Yes or no? So, there is some sort of the renal tubular electrolyte handling. So, always remember Gordon and Glittman, they are opposite to each other. In both of them, the DCT, the similar function is being affected, but in the opposite direction. So, Gordon and Glittman, please remember, they are opposite of each other. So, in Gordon syndrome, you get hyperkalemia with metabolic acidosis. So, I am already eliminating option C. Now, coming to A, B and D. It is regarding hypertension. Remember, in case of Bartter syndrome, you get normal or low BP. In case of Glittman also, you get normal or low BP. But in Liddle syndrome, there is a gain of function mutation affecting the epithelial sodium channel, because of which there is sodium and consequent water retention, and this can lead on to hypertension. So, in Liddle syndrome, it is hypertension, whereas Glittman and Bartter, it is normal or low BP. Okay. Gordon syndrome, you get high BP, but again, Gordon syndrome, it is not hypokalemia, it is hyperkalemia. So, for the answer for this question will be option A, that will be Liddle syndrome. I hope you are clear with this. So, if all of you are clear with this, just give me a quick thumbs up. Okay, but even if you are, suppose somebody, you're just beginning your preparation, sir, I've just come in to see what you're teaching, but all this looks French and Latin to me. Just understand what are the topics that are being asked. Try to understand that. Every session that you attend during your preparation phase should refine you, should give you understanding, okay, this can be asked. This is a potential question. Sir is telling that this area questions are being asked. So, you have got to develop that understanding. Got it? Okay. Coming to the last question of the RDX series. 76-year-old male is referred for further management of suspected ankylosing spondylitis. So, he was told that he had some abnormality in radiograph, which is why probably ankylosing spondylitis was suspected. He emphatically denies stiffness, pain or enthesopathy. Examination showed limited spine flexion and normal chest expansion. Inflammatory markers are not elevated, and he had no history of ocular disease or adolescent back pain. What is the most likely diagnosis is the question. So, though the patient is having a suspected ankylosing spondylitis, there are many points that tell me that this may not be ankylosing spondylitis. Number one is the age of the patient. Now, ankylosing spondylitis is definitely seen in adults less than the age of 40 years. Now, for somebody who has not had any sort of adolescent back pain, to have the diagnosis at 76 years is totally unusual. But let us see what has probably happened here. And let me again tell you, there is no stiffness, pain or enthesopathy. So, enthesitis we know is again one manifestation that can occur in patients with seronegative spondyloarthritis. Not just ankylosing spondylitis, but reactive arthritis, psoriatic arthritis, they all can have enthesitis or enthesopathy. Okay, his examination shows slightly limited spine flexion, normal chest expansion. You know that ankylosing spondylitis can have limitation in the chest expansion, and inflammatory markers are not elevated. In ankylosing spondylitis, you would definitely expect the inflammatory markers to be elevated. So, the points that I have listed are all taking me the diagnosis away from ankylosing spondylitis. Now, what else could be the diagnosis? Could it be reactive arthritis? Well, reactive arthritis means usually the patient has some sort of symptoms involving the lower limbs as well as spine. Okay, but are you seeing any sort of such manifestations? No, it is basically an incidental pickup in the radiograph, correct? Okay, So that is not going to be the answer. No skin manifestations of psoriasis mentioned, hence psoriatic arthritis is again unlikely. Pseudo gout is likely to involve where? Is it the spine or is it the knee? It is likely to involve the knee joint as a painful swelling first. So that is also not something that I will consider. I am going to consider a diagnosis of diffuse idiopathic skeletal hyperostosis, which is a close radiological differential diagnosis of ankylosing spondylitis, which unlike patients with ankylosing spondylitis presents in those who are above the age of 50 years, mostly picked up incidentally without much symptoms. So what happens is, many of you might have heard that in ankylosing spondylitis you have got syndesmophytes. How many of you have heard? Please let me know in the comment section. How many of you have heard that syndesmophytes are there in ankylosing spondylitis? Many of you have heard. Yes. But what happens in case of this disease, diffuse idiopathic skeletal hyperostosis? Diffuse idiopathic skeletal hyperostosis. What happens here is, there is calcification and ossification involving the anterior longitudinal ligament. So you can see that anterolaterally you have got an appearance which is called as the flowing wax appearance because of the calcification and ossification involving the anterior longitudinal ligaments. You do not get the classic syndesmophytes that you can see in case of ankylosing spondylitis. But seeing this appearance, some people may mistake it to be that of ankylosing spondylitis. So DISH commonly involves the thoracic spine. Ankylosing, first affects the lumbar spine, whereas DISH affects the thoracic spine first. Ankylosing can also involve thoracic, but ankylosing first involves lumbar. But DISH is usually in the thoracic spine only. Okay, so that is going to be my answer here. So diffuse idiopathic skeletal hyperostosis will be the answer for this question. So that's it. Congratulations for the students who have done well in the 𝗗nic𝗃 RDX exams. So hope you enjoyed the discussion part as well. We have done a very concise, crisp discussion. And once again, let me tell you, if you are seriously preparing for 𝗗nic𝗃, don't just join this group just because, okay, let me see what discussion. If you're not preparing for November 𝗗nic𝗃, this is just going to be a distraction for you. But if you are seriously preparing for the November 𝗗nic𝗃, you want to get a top rank, you can please join this group. We'll be doing active discussions and you can send me a message in my Instagram page. This is the QR code of my Instagram page. That's it. Thank you so much everyone for joining. It was lovely interacting with all of you. Thank you so much for joining, and I want all my children to keep studying well and always study with a positive mindset. Lots to learn, but when you have got pressure, it's important to keep your mind calm and cool. Always remember, a calm mind thinks better, okay, recollects better, answers better also. So thank you so much everyone for joining, and good luck.